last week, I think, last week or the week before, saying we'll talk about that subject, about the brain and controlling ventilation in this class, and so here we are. But thankfully it's only one part, there's not multiple parts here. And so if you look at the schedule says we're doing chapter 11 all week. I lied. We're not doing chapter 11 all week. We're doing chapter 11 today, which means...
Free day?
What's that?
Free day?
Free day?
Yeah, I'll wear my coaching stuff. We'll go play flag football outside. No, free day. What is that?
Sunny day.
Which means I will move things forward. That may potentially can turn into a free day some point down the road. Because the next topic, we'll talk about chapter 11 today, the next topic is going to be ABG interpretation, which is going to occur over multiple days. And so that gives me an extra day to discuss and go over things, because when we get to that point about blood gas interpretation, and you'll hear me say this again on Wednesday, everybody picks it up at a little bit different pace. It's not always we're all together after day 1, we're all together after day 2, but by day 3 we finally start to put the gaps in and can fill in the blanks. So that just gives me an extra day to play with when it comes to blood gas interpretation. But anyways, I don't want to get too much into that because we have that to talk about on Wednesday. So this is about controlling ventilation. The brain, which, to be fair, we still don't know a whole lot about. All right, we don't know a whole lot about the brain. But what we do know, we'll kind of discuss here. So similar to a heartbeat, breathing occurs automatically. You don't have to think about breathing. Doesn't require any sort of conscious thought. Now, holding your breath, you have to think about it. But normal breathing, you don't have to think about it. Now that I'm talking about it, you're now thinking about your breathing, right? You're thinking about how fast I'm breathing, how slow I'm breathing, how deeply I'm breathing. That's okay, because different from a heartbeat, breathing patterns can be changed. You want to breathe faster, you want to breathe slower, of course you can do that. And you can do it consciously. But I can't do that to my heart. My heart's beating, I don't have to think about it beating, but I can't consciously make my heart beat faster or make my heart beat slower. Okay, so where heartbeat, respiratory rates can be similar, but also different. Now, where is it controlled? Where is breathing, controlled? Obviously in the brain, but where specifically in the brain? In the medulla, as well as the pons. That's where breathing is controlled. Again, way down deep underneath the cerebellum, there near the brain stem itself, the pons and the medulla. And specifically in 3 separate centers or areas. The dorsal respiratory group, abbreviated DRG, ventral respiratory group, abbreviated VRG, and then the pneumataxic center. All right, so what do you need to know from each one of these? Again, I'm trying to keep this very straightforward, very simple. All right, so you can see pneumataxic center. Again, this is looking at the medulla here and the pons up top, medulla down here. The pneumataxic center, the VRG, the DRG. And again, some things highlighted here which we will mention. All right, so the DRG, located on the dorsal side of the medulla. Anybody know anatomically where the dorsal side is?
Posteriorly?
The back. Think about the dorsal fin of a dolphin or a shark, right? That's on the back. So the dorsal respiratory group's located on the back of the medulla, and it mainly consists of inspiratory neurons that signal in the brain to signal inspiration. Again, I put it in bold for a reason. DRG mainly deals with inspiration because it mainly contains inspiratory neurons. The VRG, located anteriorly in front as well as bilaterally on either side, does contain both inspiratory and expiratory neurons, but most of their functions related to expiration. Okay, so DRG for inspiration, VRG really for expiration, even though VRG does contain some inspiratory neurons. Primarily, VRG deals with expiration. Now, the pneumataxic center that's located there in the pons, they control kind of the switch off point between inspiration and expiration. Again, some folks may consider that controls the length of inspiration, and that's the pneumataxic center, how long inspiration will take. Again, the responsibility of the pneumataxic center. And again, they use the term switch off point as that transition between inspiration and expiration. The apneustic center, located here, what they believe, they've never been able to anatomically actually identify it, but where they believe is located in the lower pons, the apneustic center. It controls duration and intensity of inspirations. The one thing I wanted to point out here, patients with severe brain damage may have a breathing pattern known as apneustic or apneusis type breathing, which consists of kind of prolonged inspiratory gasps. When you get that opportunity, not that it's anything enjoyable at all, but when you have that patient begin to take their final breaths, they tend to have this very unusual breathing pattern, this apneustic breathing pattern, which again, they will have these kind of prolonged inspiratory gasps that are really unique, really different.
Is this what's referred to as a death rattle, or is that something different?
It's not the death rattle per se. Usually that sound that you're hearing is a little, again, lack of a better word, a little secretion still left around. That's why they kind of call it the rattle. But it is kind of those kind of final breaths, if you will. Kind of similar to what we would call agonal breathing. They're still breathing, but it's definitely not a normal in and out breath like you and I are taking. God bless you. All right, reflexes. Our body has multiple reflexes that can send signals back to the medulla, back to the brain, to cause various reactions. To keep it simple, probably to cause some sort of effect on inspiration. Some sort of effect on inspiration. So, the ventilatory drive, primary drive from the brain, the medulla, is modified by various sensors or reflexes that are found out in the periphery. These sensors could be found in the lungs, most of them are, but also in the muscles as well as the joints. And I don't remember counting I didn't count these. There's maybe 6 or 7 if I had a guess that we will talk about. So kind of find out something unique about each one and how does that send the signal for the body to respond. So the first one, Hering-Brewer inflation reflex. Notice it says inflation reflex. That's probably your first clue. These are stretch receptors found inside the lung, found inside the airways, both small and large airways. When they are stretched, when these Hering-Brewer inflation receptors are stretched, they will inhibit or basically stop any further inspiration. Okay, so stop any further inspiration or inspiratory effort. They're only activated when we take large tidal volumes, somewhere between 800 to 1,000 mLs. Again, think about it. Right now, you can take a large tidal volume, but that's sending a signal to your Hering-Brewer inflation reflexes to say, okay, that's enough. You don't need to take any deeper breaths. That's enough. That's enough. You can stop. Helps to regulate our rate and depth of breathing when we're doing strenuous exercise, when we're really working out hard. Additionally, with the Hering-Brewer inflation reflexes, patients who have diseases that cause problems with lung compliance. Now, when we said lung compliance in the past, I always use a stiff lung as an example of someone with low lung compliance. The lung doesn't want to easily expand because of disease, because of illness. The lung's extremely tight, extremely not wanting to expand very easily. With the Hering-Brewer reflex, this may lead to enhanced inspiratory efforts, which could increase a patient's respiratory rate. May shorten how long they spend in inspiration. So think about it. If you spend a shorter amount of time in inspiration, then you're going to take another breath even faster. And so this, for these patients who have stiff, non-compliant lungs, and we wonder, gee, why are they breathing 30 times a minute? This may be the explanation for one of the reasons why they're breathing so much faster. Is simply the effect of this reflex. Yes?
So the low compliance makes the brain think that it's
I didn't want to say that. I didn't want to say it makes the brain think anything different, but it does send a signal back to the brain to shorten how long they spend in inspiration, which in turn will cause them just to breathe more frequently, more rapidly.
That to increase the minute ventilation.
It could, because that's another part. When I say this, I'm thinking because of this issue, their volumes are probably a lot smaller.
The only way to increase.
And the only way to increase minute ventilation is just, you better breathe faster, because obviously you can't take a bigger breath in because of the disease and illness that you have going on. Herring-Brewer also has a deflation reflex, so be careful on this one. If you just memorize Herring-Brewer, it's easy to confuse inflation with the deflation reflex. So what Herring-Brewer deflation reflex does, or what it's claimed to fame, sudden collapse of the lung. For example, my abbreviation here means pneumothorax. All right, so sudden collapse of the lung, such as during a pneumothorax, will stimulate very strong inspiratory efforts and increase a patient's respiratory rate. Like if you think about someone has a pneumo, yeah, they're probably going to be in distress and they're probably going to be breathing faster. Part of that reason they're breathing faster is that signal going back to the brain. Also can be seen with what they refer to, and I'll read it and then I'll tell you what it is, with an accidental forced deflation of the lung below residual volume level. The term getting the wind knocked out of you. Anybody ever play sports or do something where you were doing something too much and you fell and had the wind knocked out of you? Anybody's ever experienced that? I'm getting a few head nods. If you did, the very first thing you're going to do is what? You're going to attempt to take a breath and nothing really happens. And think about what's happening to your respiratory rate. It's going to start increasing because you feel temporarily that you're not able to breathe, that you're not able to take a breath in. So that's this strong inspiratory effort. It's only happened to me one time, and I was a kid. I was probably middle school age, playing football. Jumped up for a ball, jumped as high as I could, and I landed flat on my back. And I remember landing flat on my back and feeling I couldn't talk, I couldn't say anything, I couldn't catch my breath for just a few seconds. That was that sensation of getting the wind knocked out of me. And yes, my respiratory rate and inspiratory effort was strong, but nothing was going in, at least for a few seconds after. Scared the heck out of me because I'm like, that's never happened to me before. I didn't know what that felt like. But that would be an example of someone having this accidental forced deflation of the lung.
I thought you were going to say something badass, like someone would tackle you and hit you right in the stomach.
I need to come up with a better story than that, yes. But no, I don't have anything better. All right, another reflex, Head's paradoxical reflex. Now, by definition, they say if the Herring-Brewer reflex is partially blocked, and I had a research, what does that mean, partially blocked due to cooling? They reference this could occur during exercise. So just file that for what it's worth. All right, of the vagus nerve, lung hyperinflation can cause further inspiratory effort, which is really the exact opposite of the Herring-Brewer inflation reflex. Remember Herring-Brewer inflation reflex, when you breathe in a deep breath, the signal tells you, well, stop breathing, stop inspiration. This is the exact opposite. It actually encourages deeper breathing. So if this is stimulated, it helps us maintain large tidal volumes during exercise. So instead of just being stuck with a 500, 600 tidal volume, we could sit there and breathe much larger tidal volumes. Think about when you're exercising and really pushing yourself hard. There's a lot of mays here because there's so much about the brain we don't know. It may be responsible for the deep sighs that we sometimes take, right? No offense when I see somebody, it's not a yawn, it's a deep sigh. That's what I'm saying in my brain. It's a deep sigh they're taking because you're trying to keep those alveoli open, keeping them from being collapsed. So a sigh breath. sigh, taking just an occasional sigh. And don't we all sigh on occasion? Not every second or every moment of the day, but probably think about it in a 24-hour, in a
Test I
12-hour period. Well, that's a different sigh. That's a sigh of frustration and anger. But just normally, you're breathing, you're not doing anything strenuous, just take a little bit extra breath. May also be involved with stimulating the first breaths of a newborn. Because again, in utero, baby's not breathing, are they? They're not taking any breaths of air. How do they survive? Umbilical cord, getting all those oxygen and nutrients from mom, and getting CO2 removed from mom. It's when they are delivered that they do take that first gasp of air. So thought, Head's paradoxical reflex is stimulating that first breath that they do take. All right, irritant receptors. I think this is probably the easiest visual that you think about. Irritant receptors. We have irritant receptors found in our lung. When stimulated, they cause us to maybe cough or sneeze, maybe even have bronchoconstriction if our airways are twitchy or very sensitive. Tachypnea. What does tachypnea mean? Faster breathing than normal, and narrowing of the glottis. Could also elicit what we refer to as a vasovagal response, which means your heart rate can suddenly significantly drop. But what causes these irritant receptors to be stimulated? Smoking, or being near someone who's smoking. Inhaling cold air. You know, we're getting to the colder season. I think Wednesday is supposed to be in the 40s in the morning, if I watched the weather man correctly. It'll probably still get up into the 70s and 80s, so it'll be hotter than heck in the afternoon, but first should be a little bit cooler, I think, later this week. But inhaling cold air, that could be an irritant. Inhaling toxic gases, among other things, also can be stimulated when we suction a patient, when we intubate a patient, and even put a bronchoscope down a patient. That can stimulate the irritant receptors. And so just picture, we're doing some of this stuff to our patients. No wonder they're coughing, sneezing. Again, we're stimulating those irritant receptors. All right, J receptors or juxtacapillary receptors. Now these are found in the C fibers of the lung parenchyma near where the capillaries are. Think about the C fibers and the C in the word capillary. This is there in the lung itself, but near where the pulmonary capillaries are. What causes these things to be stimulated? Think of illness, think of disease. Alveolar inflammation, seen with pneumonia. Think of pulmonary vascular congestion seen with congestive heart failure. Or another way to say that is pulmonary edema. All right, so these diseases, these illnesses can stimulate the J receptors. Now, how does the patient respond? Rapid, shallow breathing. They may have the sensation of dyspnea. What is dyspnea again? Shortness of breath, as well as narrowing of the glottis. So even the stimulation of some of these receptors could have the patient respond a certain way, or even feel a certain way. Peripheral proprioceptors. Now these are not found per se in the lung parenchyma or the lung itself, but these are in the muscles, the tendons, and the joints. Can be found in the muscles, can be found on the skin. They send impulses or signals to the brain or the medulla to increase respiratory activity and hyperpnea. The word hyperpnea,
Deep breathing.
deeper breathing, generally deeper and faster breathing, but deeper breathing definitely. That's why we may say for someone who's maybe passed out, why maybe moving their limbs, slapping their skin or slapping their face may be enough of a signal to awaken them, to get them breathing again. Maybe even by splashing cold water on their face. Think about it. Someone's found down, someone's found passed out. Again, you're kind of slapping their face, trying to, quote unquote, wake them up. Maybe you're able to stimulate the peripheral proprioceptors, and that's why we're doing it. That's what we're stimulating with that.
Is that why when the baby's first born, they'll often like slap their foot? Or
Yeah, part of the stimulation of the newborn child. Yes, absolutely. And last one here, muscle, I don't remember how many there were. Is there 6, 7, 8, 9? I can't remember. 7, thank you. Muscle spindles. So these are found in the diaphragm and the intercostal muscles, those muscles between the ribs. They help to cause, when stimulated, cause the muscles to contract with greater force. So again, maybe this is seen for those patients with increased work of breathing. We're seeing those accessory muscles, those non-diaphragm muscles, those other muscles, intercostal muscles, they're found between the ribs to stimulate increased breathing effort. All right, so those are all the reflexes. Okay, a lot of them to stimulate increases in rate, increases in breathing. This one obviously increased effort. Now there are some other things that can control ventilation, and we'll refer to those as chemicals. Chemicals may be found in the bloodstream. Normally, we're able to maintain proper amounts of oxygen, carbon dioxide, and even hydrogen ions in the blood by being able to regulate ventilation. So substances found in the blood can affect and cause ventilation to respond. Chemoreceptors are just one example of the receptors that can respond to some of these chemicals. They can transmit impulses to the brain or to the medulla, telling the brain, well, you better start increasing ventilation. All right, and there's two chemoreceptors: central chemoreceptors and peripheral chemoreceptors. And there are differences between both of them: central and peripheral chemoreceptors. Central chemoreceptors. Think of the word central, it's found in the brain. Okay, central chemoreceptors are found in the brain, specifically the medulla, but found in the brain. And they're influenced by chemicals found in cerebral spinal fluid. They are not in direct contact with arterial blood. They're chemicals found in the cerebral spinal fluid. All right, so dance over here for a second. Not getting too much into that chemical reaction because we're going to talk about CO2 again, sorry. So in the bloodstream, CO2, all right, CO2 is being carried. CO2 can cross the blood-brain barrier. Other chemicals cannot. CO2 can. All right, so CO2 can cross. CO2 can cross into the cerebral spinal fluid. CO2 merges with water, forms, what was that acid again? Carbonic acid. Oh, there's some stuff you do remember. Carbonic acid that will split off into bicarb and the hydrogen ion. In this case, the hydrogen ion is what sends the signal to the medulla to do what? Increase ventilation. Really the hydrogen ion that sends that signal. So we talk about chemicals in the cerebral spinal fluid. What's the chemical? It's really that hydrogen ion that sends that signal to the medulla. So what causes hydrogen ion to get there in the first place?
CO2.
The CO2. The CO2. So remember that. The more CO2, the more hydrogen ions, probably the greater the signal to signal us to begin ventilating or improving ventilation or trying to ventilate more.
That's why you don't increase so much oxygen for patients with COPD, because the trigger will not work so well.
Yes, yeah, and we'll get to that in time. We'll get to that explanation in time. But you bring up a good point. It's the CO2 that will lead to increases in ventilation through the central chemoreceptors. Do you see oxygen or lack thereof of oxygen anywhere here? No. And that's a misconception some folks have. It's not low levels of oxygen that stimulate the central chemoreceptors. It's increased levels of CO2 that send signals to the, and I keep pointing here, central chemoreceptors. All right, so when the central chemoreceptors are stimulated, what are they stimulated from? Carbon dioxide. Ultimately, carbon dioxide would cause that increased stimulation. Alveolar ventilation can increase 2 to 3 liters per minute for every 1 millimeter increase in the arterial CO2. Only 1 millimeter of increase in CO2 can cause ventilation to increase, alveolar ventilation to increase 2 to 3 liters. That's quite a bit. That's a lot of extra ventilation. Therefore, and I should have highlighted this whole statement here, it's the CO2, not O2, that is the primary mediator of the minute-to-minute stimulus for ventilation. Through which chemoreceptors? The central chemoreceptors. Now that's great and all, especially if my patient's not ventilating very well and CO2 is building up. Hopefully there is a signal getting back to the medulla, back to the brain to improve ventilation. Hopefully there is. And if it is, that's fine. That's great. Good. I'm ventilating more, trying to get rid of this buildup of CO2. But notice what happens after a day or two. That stimulus gradually declines, which sure as heck doesn't help my poor patient. I'm sorry, Connor.
So can an increased CO2, like the stimulation of central chemoreceptors, can that trigger those reflexes we were talking about earlier, or are they not?
No, that's just sending the signal back to the brain
Okay.
to increase ventilation. Hopefully if those other receptors are being stimulated, hopefully they are, for whatever reason, hopefully those are also sending signals back to the brain to improve or increase ventilation. Again, it's everything kind of all together, so to speak. All right, so central chemoreceptors respond to what? Increasing levels of carbon dioxide, increasing levels of CO2. Now, peripheral chemoreceptors still respond to chemicals found in the bloodstream, but they're going to send signals differently. Okay, and they're going to respond to maybe different chemicals or even the same chemicals. All right, peripheral chemoreceptors are small, highly vascular tissues. When you hear the word highly vascular, what do you think about? They receive what?
Blood.
Lots of blood flow. Lots of blood flow. Lots of blood vessels going there. Now, the peripheral chemoreceptors are located at 2 sites. At the carotid bodies, which is here, in the bifurcation of the carotid artery, and aortic bodies that are near the aortic arch, that big blood vessel coming out of the heart that takes the blood to the rest of our body. So aortic bodies are located there. Now, most of the peripheral chemoreceptors, most of them are found in the carotid bodies. So this is taking the patient, the body away and just focusing on the receptors. So there's the carotids. All right, there's the carotid artery. So carotid peripheral chemoreceptors or carotid bodies are located there. They send the signal back over the glossopharyngeal nerve back to the medulla. Okay, when stimulated, send the signal over the glossopharyngeal nerve back to the medulla. The aortic bodies down here near the aortic arch send signals over the vagus nerve back to the medulla. Okay, so remember those 2 nerves. Again, they're following 2 different paths, one with the carotid bodies, one with the aortic bodies. Now, carotid bodies tend to have more influence because there's more of them. They're in larger number. Okay? They receive a whole lot of blood flow, 20 times their weight each minute. And just because they're more numerous, they have more influence, the carotid bodies do, than the aortic bodies. All right, so what do they respond to? We said the central chemoreceptors only really respond to increasing CO2. So what do these respond to? There's your oxygen, or lack thereof. Someone has low oxygen levels, that's going to be recognized by the peripheral chemoreceptors. And it's the peripheral chemoreceptor that sends the signal back to the medulla to say, okay, brain, make them breathe more, make them breathe better. They also respond to elevated CO2. So there's our elevated CO2 again. Now they don't have as much influence over the peripheral chemoreceptors as the low oxygen does. That one definitely does most of the signaling. But having elevated CO2 can still stimulate the peripheral chemoreceptors. And having blood that's acidotic, all right, acidotic blood. And we'll get to acidosis, alkalosis on Wednesday when we begin talking about blood gas interpretation. But acidotic blood can also send a signal back to the brain. And the ventilatory response is 5 times faster compared to the central chemoreceptors, and primarily it's because the peripheral chemoreceptors are in direct contact with arterial blood. So they're getting that response much faster, as opposed to having to go through the arterial blood into the cerebral spinal fluid to send that signal. All right, so everybody okay with the 3 things that can stimulate the peripheral chemoreceptors versus the one thing that stimulates the central? All right, so central, it's the elevation in CO2, causes the patient to want to ventilate more. Peripheral, primarily the low oxygen, but also elevated CO2 and also the acidotic blood, so low blood pH. All right, during strenuous exercise, carbon dioxide production, oxygen consumption significantly can increase. Here it says it can increase 20-fold, and that's fine. It definitely increases, especially when we're working out vigorously. But it's matched by an increase in ventilation, as well as an increased cardiac output, that blood amount being pumped out of the heart per minute. And all of that keeps our blood pH, our blood CO2, and our blood PO2 normal. Even though I may be breathing faster, even though my heart's beating more frequently, more blood volume is being pumped out, all of that is, the reason it's doing it is to keep my blood numbers still the same. A normal CO2, a normal PO2, even a normal pH. Because if it didn't, every time I would work out vigorously and breathe fast, what would happen to my CO2? It would go down, because I would get rid of it so quickly. But no, normally we increase ventilation, we increase cardiac output because there's more CO2 in my body and I'm just trying to get rid of it, all right? To keep everything still normal, a normal value, normal level. All right, the chapter did talk about one breathing pattern in particular. There's several different types, but one breathing pattern in particular it mentioned, known as Cheyne-Stokes breathing. With Cheyne-Stokes breathing, God bless you, the patient's breathing pattern is going to look a little unusual. If you sit back and just watch them breathe for a minute or two, you will see periods where their volumes, bless you, start smaller and get progressively larger, and then get progressively smaller, and then there's periods of complete, absolute apnea, where they're not breathing at all. And then they slowly start to breathe again, volumes start a little small, they get progressively bigger and bigger and bigger, and then kind of start to taper off, smaller and smaller and smaller, and you still have these periods of apnea. Now what happens with Cheyne-Stokes breathing, blood flow and the lack thereof of blood flow sending CO2 in the blood, O2 in the blood, back to the brain or back to the peripheral chemoreceptors is being affected. And so the transit time between the blood sending the signal and the signal sending the ventilatory muscles to increase or decrease ventilation become affected. It's all seen when blood flow rates become slowed. CHF is a common example where we see blood flow rates really significantly drop. And so that signal between what's in the blood and the signal getting back to the brain, there tends to be a little bit of a lag. And so that's why you see their breathing depth of ventilation increase, and then it thinks, okay, the CO2 is really low now, so let's back off on ventilation. And then it thinks, wait, the CO2 is still too low, so let's stop breathing to try to retain some CO2, and then a period goes over again. And so you really get this kind of crazy chaotic breathing pattern. But again, they call it Cheyne-Stokes respiration or Cheyne-Stokes breathing. Now, carbon dioxide can affect cerebral blood flow. When I say cerebral blood flow, that's blood flow going where? To the brain. To the brain. All right, so CO2 can affect cerebral blood flow. So, increased levels of CO2, can dilate the blood vessels, cerebral blood vessels, and increase cerebral blood flow. Okay, so CO2. If we allow a patient's CO2 to build up, it can cause cerebral vasodilation and increase blood flow to the brain. If that's true, then that means the exact opposite is also true. if I reduce CO2, I cause the cerebral blood vessels to constrict and cause less blood flow going to the brain, decrease in cerebral blood flow. Now, is either one good? No, we need a happy medium. But CO2 can affect blood flow going to the brain. The higher the CO2, the increase in cerebral blood flow. And the exact opposite is true. The less CO2, the less cerebral blood flow goes to the brain. Now, what's the I'm sorry, go ahead.
And that's our body trying to compensate, to get increasing blood flow, to get rid of the carbon dioxide, or keeping it in, constricting?
Not necessarily, but what happens to the blood vessels in the brain, whether it's CO2 levels, again, normal CO2 levels, the diameter of the blood vessels would be normal. But if I let CO2 build up, blood vessels in the brain will dilate, increase in cerebral blood flow. And if I let the CO2 go down, then that's going to cause constriction of the blood vessels in the brain and cause less cerebral blood flow. So the point of all of this is the situation I'm about to share with you, traumatic brain injury. All right, traumatic brain injury. Marlon, why did I use these pictures? Why are the Chargers on here?
Right.
Chargers inflicting punishment. I have a good picture of a Charger player getting crushed. I can't put that on here. But you see something like this, something that caused traumatic brain injury. Okay, traumatic brain injury. So I tried to get some of the most extreme examples of somebody getting struck in the head, right? All right, so with traumatic brain injury, the brain will acutely swell, causing increases in intracranial pressure. Increases in intracranial pressure. Increase in intracranial pressure could potentially cut off the supply of blood to the brain, leading to cerebral hypoxia. Hypoxia generically means what? Hypoxia? Low oxygen at the tissue level. You throw the term cerebral, that means lack of oxygen. What tissue? The brain. The brain, which obviously would not be a good thing, lack of a better word. Not be a good thing for somebody to suffer with cerebral hypoxia. That's with increasing intracranial pressure. So an increasing intracranial pressure of, say, 20 millimeters of mercury or higher places the brain at significant risk for ischemia. What's ischemia mean? Tissue death, lack of blood flow, lack of oxygen getting to the tissues. And so anything in excess of 20 or higher would require active treatment to reduce intracranial pressure. Now, in case you're curious, well, what's a normal intracranial pressure? Generally think of it as a single digit, something less than 10, single digit. We see patients with elevated intracranial pressures that are much higher than 20. Again, very scary situations. A lot of times don't think this is going to be compatible with, or it's going to lead to a poor outcome, not compatible with survival, things of that nature. So try to bring that intracranial pressure down as much as possible, okay? Now, guess what? By thinking about how we can use CO2 to our advantage may help a situation like this. And so the term mechanical hyperventilation. If you hyperventilate, start breathing faster and or deeper, okay? What happens to your CO2? Gets rid of it. CO2 can go down. So remember, CO2 is a cerebral vasodilator. If I let it build up, blood vessels will dilate, and what's going to happen to intracranial pressure? It's going to go up. So the school of thought with mechanical hyperventilation is, let's intentionally, and these are patients on ventilators, let's intentionally overventilate them to get rid of their CO2. Let's cause cerebral vasoconstriction to keep the pressures down. And that's why we do it, to keep the intracranial pressure down. So if we can reduce the CO2 by 1 millimeter of mercury, we will reduce cerebral blood flow by 3%. And that's going to cause intracranial pressures to go down, okay? Which would lower intracranial pressure. Now that's good in theory, right? And we've done this for years. But think about what we just said. If I keep the CO2 lower, that causes, what is this?
Cerebral blood flow.
That means less blood flow going to the brain. Is that a good thing? It's a catch-22. It's a damned if you do, damned if you don't type thing. Yes, we want to keep intracranial pressures down. So I don't want to add any excessive fluid, blood, going to the brain. So let's keep intracranial pressures down. But at the same time, I can't just say, well, let's keep the CO2 as low as possible and cause significantly lower amounts of blood flow going to the brain, because what does that mean to the brain? Well, now the brain's going to not get as much oxygen, and then cerebral hypoxia all over again. So it's a fine line. It's a fine line. So when we do start to see the situations where we are ventilating patients with elevated intracranial pressure, okay, it does require a lot of work and a lot of effort, because it's a very fine line. I typically want to over-ventilate them, but I don't want to go crazy with the over-ventilation for the fact of this. And yes, this causes intracranial pressures to go down, so yes, I want intracranial pressures to go down, but I don't want to cause where there is less oxygenated blood going to the brain. So there's a fine line. So when it comes to, and we'll get to this more in depth later, there's a very specific CO2 level we try to maintain. Yes, it's less than normal, but we don't want it to be too low. So it is something we will target their CO2 to be a little less than normal. And generally when we do this, and again, it's the respiratory therapist that's doing this with the ventilator, generally it's the first 24 hours of the incident. Beyond that, studies have shown it really doesn't, it's not effective after 24 hours. But if anything, at least that first 24 hours gives us time for other treatments involved into bringing intracranial pressures down. And we'll get into those other things later. This chapter was just trying to focus on CO2 and its effect on cerebral blood flow and its effect on intracranial pressure. Questions? Okay, short and sweet. I know, you want to talk about blood gases, that's all. All right, so questions. When stimulated, the DRG, dorsal respiratory group, mainly sends motor impulses to influence inspiration, expiration, coughing, or bronchospasm. Inspiration. I don't think I asked. I don't remember. Helps if I look at these questions before class. Okay, I don't ask it. If I replace DRG with VRG, what would be the right answer? Then it would be expiration. But VRG, don't forget, does have some inspiratory neurons, but mainly expiratory neurons. Are everybody okay with this one? Have a picture? All right, so the answer, So the answer here was A. But if I change that to VRG, then the new correct answer would be B. All right, next question. The peripheral chemoreceptors located in the aortic body send impulses over which nerve to the DRG, or back to the medulla? Is that the vagus, glossopharyngeal, phrenic, or radial nerve? This one? It's a 50-50 because there's only the vagus and glossopharyngeal that send signals from the peripheral chemoreceptors. So is it vagus? Okay, it is vagus. Now, that's right, there you go. So, you know, I can reword this question, replace the word aortic bodies with carotid bodies, and now we would have a new right answer, right? Okay, so you guys are all, you guys have been with me enough now that you know, yeah, John gives me this question on the review after the lecture, and then on the test, he doesn't give me this question, he changes it. Okay, so you guys are smart enough now, you're catching my game to figure out the questions I will ask when we test. And it looks similar, sounds similar, but it's not the exact same question. All right, which reflex control of breathing is activated by splashing cold water on someone's face or skin? Herring-Brewer, head paradoxical reflex, peripheral proprioceptors, muscle spindles, or irritant receptors? C, peripheral proprioceptors. All right, so this one was C. Questions? Got that picture okay? Jot that down. And in the brain, if CO2 levels increase, what happens to intracranial pressures? If CO2 levels go up, what happens to intracranial pressures? They will also go up. They will also go up. I needed another answer. You could see when I'm giving tests and I have nothing creative or good, I come up with the obvious.
Smile during the test.
Oh, that's good. I'm still waiting to see somebody smile during a test. You look at that and just frown and move on to the next one.
You missed my smile with Gluteus Maximus question.
Did you? Okay, yeah. I didn't see anybody laugh or chuckle on that one. All right. Any questions on this one? Okay. Now, like I said, Wednesday we'll do blood gas interpretation. Okay, so before the next class, do me a favor. If you can memorize just the normals, okay, just the normals, it would help so much when we go over interpretation. Okay, so those are the normals I want you to know. Okay, those are the normals I want you to know. These values are actually not under chapter, what did we just do, 11? They're not found under chapter 11, but if you go to the next section that I entitle ABG Interpretation, they're found there. Okay, if you want this slide or this image, they're found right there, but in the next section after chapter 11. So I think chapter 11, I say ABG Interpretation, no chapter in textbook. So this will be a very big help to you and to me if you know what the normals are, so that on Wednesday when we start talking about how to interpret, at the very least you know what it's supposed to look like. And then when we start saying things are abnormal, well, you know what it's supposed to look like. You know where to start. And then you can go from there when it comes to interpretation. And like I said at the beginning of this class, ABG interpretation, you may, some students remember it vaguely from A and P. Some students actually say, I remember us talking about acidosis, alkalosis, but I don't remember any of it. And I get it, no offense. But we have to know this like the back of our hand, because we will be drawing the blood gases. Obviously, we'll be seeing what our patient's numbers are, and we have to know what is wrong with those numbers. Because ultimately, and this semester, I'm tickled that we get to the point you can interpret what it is. And that's huge. That's huge. Being able to interpret what a blood gas is. And you could say, well, isn't there an app for that? I'm sure there is. I'm sure there's a million apps for it. But you're not going to use an app during the test. You're not going to be able to use the app during the board exam. I wouldn't want you using an app at the bedside, because that means you have no clue what you're doing. But we're ultimately, once we move past interpretation, you know what the next big step is? Great, you can interpret that it's abnormal and it's wrong, but what are you going to do to fix it? Because that's what we're moving into when we get into next semester and semesters thereafter. What are you going to do to fix it? This semester has been able to interpret it. We can call it out what it is. I don't know what that means, but I can sure interpret it. But we're moving into, after that, okay, well, what are we going to do to fix it? Fix it, feel it. Okay? All right, questions you guys have for me before I let you guys run? Yes?
So the central receptors messages travel through the cerebrospinal fluid?
Correct.
And the peripheral messages travel up the nerves? The signal transmits up the nerves. Okay.
The signal for the centrals, because that fluid's already in communication or contact with the brainstem, it's right there. It's right there. As far as where's that cerebrospinal fluid, where's the CO2 coming from? It's coming from the arterial blood, but it does have to cross into the cerebrospinal fluid. As opposed to the peripheral chemoreceptors are in direct contact with arterial blood.
Right.
And so they can send the signal that way.
Thanks.
Oh, you're welcome. Yeah, there you go, like that. All right, any questions, guys?